Mic. Okay, we're good. I have quite a low voice, so let me know if you need me to project a little bit more.
Or you could use the mic.
Or I could use the mic. Just raise your hand if you have trouble hearing me at any point. I'm delighted to be here. I'm also very, very relieved that you did not invite me to come a few days previously when I think you were in a deep freeze. I grew up in New York City, but I've been living in Atlanta for about 10 years, so I've gotten kind of spoiled. I'm going to spend the next hour with you talking about vulnerability to HIV among people who use drugs in rural Kentucky. Before I start, I just want to recognize my remarkable colleagues on this project. I have the honor and the pleasure of working with Dr. April Young. She and I co-lead the project I'm going to be talking about today. April is on faculty at the University of Kentucky. She's really a remarkable partner in this work. I also just want to recognize the contributions of several trainees, and their names are underlined here. David Cloud, who actually got his MPH here, I believe, in System Medical Sciences, Nadia Prude, Umed Ibragimov, Monica Fadenelli, April Ballard, Evan Batty. They're all MPH and PhD students now, and I'm very, very fortunate to get to work with this next generation of scholars. Now, somehow this is not advancing. Is it maybe not connected? Oh, there you go. Okay. Either one. Okay. There, you did. Okay, perfect. My plan today is to talk about vulnerability to HIV among people who use drugs in rural areas. Then I'll talk about the methods and the results from the Care to Hope project, which is a study located in rural Kentucky. I'll close with some preliminary thoughts on implications for or findings for interventions. So as you know, we are living through a seismic epidemiologic shift in which problematic drug use and related harms are expanding from cities like New York to rural areas. And for the national public health system, I think the wake-up call to that crisis was the HIV outbreak in Scott County, Indiana. Scott County is a primarily rural county that experienced the fastest moving HIV outbreak that has ever been documented in the US. And that outbreak occurred primarily among people who injected drugs, Opana and other kind of prescribed opioids, and it was first detected in 2015. I believe that there are now about 220 people who became infected with HIV as a result of this outbreak. So shortly after this outbreak was detected, the CDC conducted what is now a very well-known analysis to identify U.S. counties that were vulnerable to new HIV or HCV outbreaks. And the CDC ranked counties by a vulnerability index, and they found that the counties in the top 5th percentile of this ranking were, in their words, overwhelmingly rural. Subsequently, we've generated more and more evidence of a rural crisis of drug-related harms. So rates of overdose deaths are higher now in rural areas than they are in cities. The population experiencing the greatest incidence of hepatitis C in the U.S. are now young adults living in rural areas. And we're also seeing rising incidences of many other drug-related harms in rural areas like endocarditis and neonatal abstinence syndrome. As you can see from the figure on the bottom of the slide, the rate of neonatal abstinence syndrome, or NAS, is now higher in rural areas than it is in cities. I want to note, though, that this 2015 wake-up call came far, far too late for many people in rural areas. If you look at trends and overdose death rates among men, for example, you can see that these rates were rising across the U.S. starting in the early 2000s. And according to a CDC analysis, by as early as 2005, almost 15 years ago, the rural death rate was higher than the urban death rate, and rates of NAS in rural areas started diverging from rates in urban areas as far back as 2009. Hepatitis C has been plaguing Appalachia, Kentucky, and West Virginia for decades. So the fact that the national public health infrastructure started mobilizing in 2015 is, to me, a really clear and tragic failure of U.S. public health surveillance and response systems. And from my perspective, as someone who's been working with people who actively use drugs since I was about 18, it's really yet another, I think, consequence of our propensity to devalue the lives of people who use drugs in this country, and also the people who love them in their communities. In the midst of these overlapping crises, though, that we're tackling so belatedly, I think we do still have a window of opportunity to mobilize to prevent HIV before it devastates communities as overdoses have, neonatal abstinence syndrome, and other health problems. And that's one purpose of the Care to Hope project that I'll be talking about next. Care to Hope, I'm terrible with acronyms. April came to my rescue. Care to Hope stands for Kentucky Communities and Researchers Engaging to Halt the Opioid Epidemic. And our project is working in 12 rural counties in eastern Kentucky. These counties are covered by 2 health districts, the Gateway Health District, which is highlighted in the map in yellow, and the Kentucky River District, which is highlighted in, I think that might be teal, not sure. Both health districts are located in the heart of the Appalachian region, and that's shaded with lines on the map. The project is part of the multi-site rural opioid initiative. That initiative is funded by NIDA, SAMHSA, the CDC, and the Appalachian Regional Commission. My understanding is that this is the first time that NIDA has actually partnered with either the CDC or SAMHSA or the Appalachian Regional Commission on any initiative, which is kind of shocking, but that's where we are. This initiative is designed to study and intervene in opioid-related epidemics in 8 rural areas in the U.S. So in addition to Kentucky, there are sites operating in rural Ohio, West Virginia, Illinois, New England, North Carolina, Wisconsin, and Oregon. Care to Hope itself was designed to achieve 2 overlapping aims. The first aim is to partner with community coalitions to assess the local opioid epidemic in each county, each of those 12 counties, and then also assess the resources and needs of each county's risk environment. And I'll talk about what that is in a moment. The second aim is to implement evidence-based public health interventions in each county to address the local opioid epidemic, and we're implementing those really based on the findings from the needs assessment, and we're going to be implementing those within the context of a stepped wedge community randomized trial. I'll be focusing on the first aim today. We have not started the randomized trial, so I would have very little to say about that. First aim is going to be the focus for today. We applied the risk environment model to explore the ecology of the local opioid epidemics in these 12 counties. Many of you may be familiar with this model. It posits that individual vulnerability and resilience to drug-related harms, including HIV, are shaped by features of the political environment, the social environment, the economic environment, and the physical environment, operating at both the micro and the macro levels. A key assumption of this model is that features of these different environments interact with one another across levels to shape this vulnerability and resilience. The risk environment model is one of the principal theoretical models that's been used to analyze the determinants of HIV among urban residents who use drugs, but this is really one of the first times it's been applied to a rural setting. We chose to work in these 12 counties for a couple of reasons. First, April had been co-leading the SNAP study in the southern end of the Kentucky River District for years, and so she has ties there, and then we also have some research infrastructure there. Second, these are counties that ranked very, very high in the CDC's vulnerability index. Our project area, for example, includes WOLFE County, which is ranked #1 in the country for vulnerability, and 9 of the other Care to Hope counties are in that top 5th percentile that I referenced earlier. Yeah.
Can you say something about the vulnerability index?
The vulnerability index?
Because I'm not sure people are familiar.
Sure. So Van Handel and several colleagues who I think are based at the CDC, they analyzed existing data on a whole lot of county level phenomena to try to identify, what are the counties that might be at greatest risk of an imminent injection-related HIV outbreak or hepatitis C outbreak. They ranked, so they did this analysis across, there are 3,000 some counties in the United States. Then they identified the counties in the top 5th percentile for vulnerability. And there's been a lot of focus on that top 5th percentile. Yeah. There's been some contention around the methods, which I think is healthy. I know people are trying to rerun some of those analyses using different assumptions. I think it's an important starting point, but I don't think it's the end all and be all. Yeah, it's a good question. These 12 counties are deeply impoverished. The poverty rate ranges from about 22% to 45%. Just to give some context, the federal government defines a poverty area as a place where the poverty rate is 20% or higher. So all of these counties would meet that definition. The Care to Hope project encompasses Owsley County, which is actually one of the poorest counties in the U.S., if not the poorest county in the U.S., and it has a poverty rate of 45%. Many of these counties were or are coal producing. If you look at the bottom row of the table, those are counties that have the check marks in that bottom row. So some of the local poverty that we're seeing in these areas is driven by the demise of the coal industry and by our failure to find other kind of replacement industries. This is also a very rural area. So as you can see, there are between 28 and 83 people per square mile in these counties. For contrast, I grew up a few miles south of here. I think in my building alone on my floor, there were probably 28 people or more. So a very, very different setting from what many of us, I think, are used to. I'm always nervous when I share this kind of information about a kind of distant place that people might not have been to, that I'm really compounding stigma. And I want to just take a moment to recognize that these counties have multiple assets, right? So they have 2 strong hospitals. Morehead State University is located there. That's a university with really strong academic programs in nursing and physical therapy and geography and a whole host of other disciplines. This area is also just stunningly beautiful. This is WOLFE County, and that's home to Boone National Forest with its waterfalls and kind of amazing hills. April keeps trying to get me to go camping with her, and she's always, secretly packing camping gear in her in the back of her car. I keep finding, tent poles and Bunsen burners mixed in with my tape recorders and informed consents. I've been resisting, but it is really quite beautiful there. I'll give her that. And it is also a place that's been reeling from a devastating opioid epidemic for at least 2 decades. And so this is where we've located the Care to Hope project. Care to Hope is gathering data using multiple different methods. Today I'm going to focus on our survey and also on some of our qualitative data. In terms of surveys, we have the SNAP study, which is led by Jennifer Havens and April Young, running in the Kentucky River District. SNAP is a cohort of people who use drugs to get high and kind of live in that area. And then April and I have also created the Gateway to Health cohort to the north in the Gateway District, and I'll be focusing on that cohort today. And I want to just give April credit for really taking the lead on developing this cohort. There we go. So to be eligible to take part in Gateway to Health, you have to be an adult resident of the Gateway Health District, and you have to self-report using opioids to get high in the past 30 days or injecting any drug to get high in the past 30 days in that period. We recruit participants into the study using respondent-driven sampling, and participants complete an interviewer-administered survey every 6 months that queries HIV-related risk behavior, overdose, hepatitis C, and a whole host of other health and health service topics. Participants are also tested for HIV, hepatitis C, and syphilis, and today I'll be just presenting simple descriptive statistics about this cohort. We have a qualitative component in which we're interviewing people who use drugs about their vulnerability to HIV and other harms, and also the risk environment that they're living in. Most participants are members of the Gateway to Health cohort, and that's how we recruited them. We're also interviewing community leaders, and today I'll focus on our interviews with pharmacists. We've been analyzing these transcripts using grounded theory methods. So let's turn to the survey results first. We have, at this point, 246 people in the Gateway to Health sample. We're aiming for a sample of about 500. The mean age for the sample is 36, so it's relatively young, or young for me. More than half of the sample are men, and like the area, the vast majority of our participants are non-Hispanic white. We've been struck by the very high rate of homelessness in the sample. About a third of our sample has been homeless in the past 6 months. We're seeing high rates of homelessness, not just in the Kentucky site, but actually across all of the 8 rural opioid initiative sites. Given the sampling criteria, it's not surprising that most people's drug of choice is some kind of an opioid like heroin or an opioid painkiller. But I do want to note that about a third of our participants are using methamphetamines, and someone here is working on methamphetamines. Yes, so that's clearly the next direction for this epidemic in this area, and we're also seeing a shift toward methamphetamines at several other rural opioid initiative sites. So we think about this as an opioid epidemic, but I just want to be really clear that it's much more complicated and it's evolving over time. About a third of the sample reported injecting a drug in the past 6 months, and most people inject daily or more often. The Gateway to Health sample reports quite high levels of injection-related HIV and hepatitis C risk. Participants are engaging in receptive syringe sharing about 8 times a month on average. Many people are not aware that you can transmit HIV or hepatitis C through sharing cookers or water or cotton. So there's a lot of sharing of other injection equipment. I think about 16 events in a month, and I suspect that that's an underestimate. Participants are sharing injection equipment with about 2 to 3 people on average in any given month. So there's clearly a lot of opportunity for HIV transmission, and about 2/3 of the sample is testing positive for hepatitis C. So far, no one's tested positive for HIV. The most commonly cited reasons for sharing syringes are not having access to sterile syringes or injecting with people that you trust, like a sex partner or a family member. Turning to syringe access, we're really delighted that 43% of the sample reported getting at least one syringe from a local syringe exchange program in the past 30 days, and another third reported getting these syringes from a friend who might have gone to the program on their behalf. Unfortunately, though, we still see high percentages of our sample acquiring syringes through sources that don't guarantee sterility, like friends or dealers. We have mixed findings about access to drug treatment. So on the one hand, about a half of our participants report getting some kind of help for their addiction or their dependence in the past 6 months, and that's promising, though this question is quite broad, so the kind of help is, it might not be evidence-based drug treatment. On the other hand, high percentages of our sample tried to get into treatment and could not. So about a quarter of the sample tried to get into buprenorphine treatment, but were not able to quite recently. Do you all know what buprenorphine is? It's like methadone. It's a medication-assisted treatment for opioid use dependence. If we expand that picture out to encompass medical care more broadly, we find that a dismaying 47% of the sample needed medical care in the past 6 months, but were not able to get it. And just as a reminder, actually, Kentucky is one of those conservative states that actually did opt to participate in Medicaid expansion. So this is not just about, poor access to insurance. Turning to sexual risk for HIV, we find pretty high levels of unprotected sex in the cohort. So on average, participants report having sex without a condom about 12 times in the past 30 days. We see very little transactional sex, but I have to say that I've wondered if this might be a reporting issue. In the qualitative work that we do, people talk a lot about seeing transactional sex in different settings, about people that they know who are engaging in it, but no one actually owns up to engaging in it themselves. So I think it might be a reporting issue. It's very, very stigmatized in this area. So risk behavior alone does not fuel HIV outbreaks. Much rests on network structure. And we know from April Young and Jennifer Havens' great work in the SNAP study that the networks of people who use drugs in the Care to Hope project area are extremely dense, which is maybe not surprising for a rural area, right? And you can see that in this diagram. And these dense networks would allow HIV to rapidly move through this population if it entered the area, and that was certainly the case in Scott County. So to summarize, the survey data revealed that a high percentage of the sample is routinely injecting with used injection equipment and engaging in condomless sex, placing them at high risk for HIV should HIV actually enter the community. And network data indicate that HIV could move rapidly through the community once it was introduced. The critical question that I want to explore next using the qualitative data is what features of the local risk environment might be creating this vulnerability to HIV in this particular rural area. I'm presenting data today from the first 19 participants that we've interviewed. Their characteristics were quite similar to that of the Gateway to Health cohort. Our analyses, which are ongoing and therefore somewhat preliminary, suggest that vulnerability to HIV in this group is driven by a constellation of intersecting macro level and micro level features of the political, social, economic, and physical environments. I'd like to dedicate the remainder of this presentation to illustrating 2 or 3 of these intersections. So the first illustration is about the risk environment and MAT access. The second concerns access to sterile syringes. And the third, I'll cover if there's time, that concerns the risk environment and what are called trap houses, which are very high risk injection settings. So let's start with MAT. As I said, MAT is really the primary evidence-based treatment for opioid use disorder that we have. It's like, it includes methadone, it includes buprenorphine, and other naltrexone. MAT is really a vital tool in efforts to reduce vulnerability to HIV and other drug-related harms. There's been a lot of research about barriers to physician prescribing of buprenorphine. You need to have a waiver to prescribe this medication. That means that the physicians have to go through a training. Most physicians don't go through that training, so they don't actually have the capacity to prescribe buprenorphine. Furthermore, many of the physicians who do actually get this waiver, who go through that training, they actually fail to prescribe buprenorphine, so they have no patients who are on MAT. So if you see a map of people of the physicians who have the waiver, that doesn't necessarily map on to access to buprenorphine. There are, I think, very important physician-level barriers that we need to continue to grapple with, but our work in Care to Hope has uncovered, I think, another set of barriers at the level of the pharmacy that's impeding the kind of push to get buprenorphine out into the community. And that's what I'll cover now. So starting with the political environment, the pharmacists that we interviewed, I think 15 of them so far, reported that the DEA monitors the percentage of all controlled substances that each pharmacy dispenses that are opioids, right? The denominator is controlled substances, numerator is opioids. Buprenorphine is, of course, it's an opioid, so it contributes to that percentage, that numerator, right? Pharmacists are deeply aware of this monitoring, and they know that the DEA has set a threshold for this percentage. They understand that the DEA will investigate them if, in fact, their prescribing of opioids, including buprenorphine, crosses that threshold. No one knows what that threshold is, as the quote on this slide attests, but the pharmacists desperately don't want to cross it, right? They don't want to be investigated by the DEA. One player in this system are the wholesalers who also track pharmacy dispensing. So they're the ones who are kind of selling in bulk the medications, and they're tracking dispensing. And they will just simply refuse to sell buprenorphine to a pharmacy if it crosses the DEA threshold. So there are repercussions to crossing that threshold. Most pharmacists handle this DEA cap by treating pharmacy level policies, by creating pharmacy level policies to limit the number of buprenorphine prescriptions that they dispense. And there are multiple different kind of policies and protocols that they create. Some pharmacies try to set their own internal cap on buprenorphine dispensing. So several places thought that the cap was at 60 prescriptions per month, and so they limit themselves to dispensing 2 buprenorphine prescriptions a day. Others try to ration based on customer characteristics. So the pharmacist quoted here tries to limit buprenorphine dispensing just to loyal customers, customers with whom he has a standing relationship. Other pharmacies will only fill buprenorphine prescriptions for local residents. That's the case with this pharmacist here. Overall, the DEA cap, I think, has transformed buprenorphine into a precious and rationed medication in this area. And the pharmacists are in the unfortunate position of having to develop protocols to decide who gets it and who doesn't, right? So that decision is not just happening at the level of the patient, not just happening at the level of the physician prescribing, but it's also now happening because of the cap at the level of the pharmacies. These protocols, I think, protect the pharmacies from DEA scrutiny, which is important, but they curtail access to a vital tool to address the local opioid epidemic and possible HIV-related outbreaks. Yeah.
I kind of always assume that pharmacists have like a legal obligation. If you have a prescription, I thought they would have to, they can choose any drug, they can choose if they're not a dispenser, based on their need.
So I was shocked. I used to work at a methadone program, right, where we would dispense, methadone like on site. So the whole idea that there was this additional layer of pharmacy, all for having the pharmacies dispense. But so that was something I hadn't really considered. And, you know, I don't know if they're allowed to make that call. I think, you know, now in the midst of the opioid epidemic, pharmacists are getting entrusted to make those calls more often. They're being kind of actively enlisted in, you know, the prescription drug monitoring programs. So we've actually, April and I, kind of based on these findings, this is the beauty of qualitative research, right? So based on these findings, April and I are now working with her colleagues at the University of Kentucky's Pharmacy School, just to try to understand, you know, are you actually allowed to kind of reject a prescription? I'll say in a moment that, in fact, there are 2 pharmacists out of the 15 who categorically refuse to fill any buprenorphine prescription whatsoever. So I don't know what they're allowed to do.
I think this is America, and it's a store, and
Yeah.
they can say, I'm a store, and I won't sell you my goods. If you come into my shop and you want to buy detergent, and I don't want to sell you detergent, I say, you know, it's not for sale. So then you can go and say I'm being discriminated against. But these are disempowered people, so they're not going to be able to do that. So it's not a government. There's no government watchdog for your store. If you were selling it illegally, certainly, but not if someone comes in and says, I want to sell that to you, then I'll never walk in this pharmacy again, but there's no repercussions for that.
No, I thought providers are also somewhat on the side. I don't think it's
No, that's okay, please,
Yeah, so like a doctor can say, you know, I think it's illegal to say, like, I won't perform this surgery because it was
No, it's not illegal. No, except the only one, the law is EMTALA is the only law that mandates care, and that only applies to emergency. So, I mean, even hospitals can refuse admission of people in emergency departments.
Plenty of people come in and say, I have a cold, I want penicillin, and I say, I don't prescribe penicillin for colds. And they say, well, I'm going to find the doctor who does, and I say, that's fine.
Susan, did you want to?
That's okay.
Yeah, so very complicated discussion. If you're operating in an area where there are just 2 pharmacists and both of them refuse to fill the prescription, that becomes a kind of community level issue. I think, you know, the pharmacists, they're trying to walk this line between being a business and then being healthcare providers, and it's incredibly tough. Yeah.
Do the pharmacies in this area carry naloxone and Narcan?
So I'm not going to talk about that, but can I tell you, like, that has been one of the weirder experiences. So most of them do, but it's expiring on their shelves. And I think it's because it's too expensive. So you actually, you don't at this point need to have a prescription to get naloxone in Kentucky. You can just walk into a pharmacy and get it. Say it again?
You have to pay for it.
You have to pay for it, and it's very expensive. And I just think that a lot of people, they don't know that you can walk in and get it, and then it is also incredibly expensive. Yeah, but it's expiring on their shelves. Yeah. Yeah, Amy.
No, I would just say, and in our work, we've also found pharmacies that are owned by larger corporations.
Yeah.
And those larger corporations will also have different rules and regulations.
That's,
and things. So there's this added level on top of just the individual pharmacist.
Yeah.
Of, you know, other layers of opinions about who should get what when.
Yes. Yeah. Susan.
Okay.
Well, my old friends are chiming in.
So I'm Staten Island task force.
Oh, yeah.
I just want to give a tiny anecdote. This is an activist pharmacist who's so wonderful. But he describes, even for him, someone comes into his drugstore, which is owner-owned, so he wants you to be able to be progressive. If they're high or they're requesting a prescription fill, that's something that he would hesitate about because he doesn't want them to overdose. So I just want to say that it sounds ugly, but you know, I think it's some of this.
That's right.
You know, because the people on can't really actually hear the questions, so it'd be good if we can get through and.
Oh, that's true. Sorry. Yeah, I apologize. Did you want to?
No, it's clarification is good, but not extended discussion.
Yeah. But why would the DEA have a cap?
So I think it goes back to the pill mill, right? So I think there's just a lot of concern that there are, physicians who are just massively overprescribing opioids. And then there are maybe pharmacies that are complicit. So I think that is where this idea of, monitoring the percentage of controlled substances that are opioids, I think that's where this push came from. But this is treatment. I would agree. Yes, thank you. So the DEA cap, though, it's not the only feature of the risk environment that curtails buprenorphine dispensing. For many pharmacists, buprenorphine dispensing is further curtailed by features of the economic environment and the social environment. So this goes back to the exchange we just had, that at the economic level, I think, this is an area where there was, in fact, a long history of, push by the Sackler, the manufacturers of opioid painkillers, a big push for that, a lot of overprescribing by physicians. And I think that's left some pharmacists feeling very leery of prescribing doctors, of doctors who are now prescribing buprenorphine. They feel that many of the doctors who are currently prescribing buprenorphine, they were also kind of complicit in the pill mills. So for years, they might have been prescribing large quantities of opioid pain pills for very little reason except their own profit. And now these same physicians are labeling their patients opioid dependent, and now they're prescribing buprenorphine for them and not making any attempt to potentially, taper them down. And so for those pharmacists, they really have they feel like the buprenorphine is really being fueled by greed. And you see that in, in this slide. It's more of a greed thing. Pharmacists who worry about prescriber motives, they also tended to voice quite a lot of stigma against people who are using drugs. So they tended to call people who are using opioids to get high, they call them druggies or use other kind of derogatory names. And they expressed a lot of skepticism about whether any of their patients might have become dependent through a legitimate medical need. And that's evident, I think, in this quote here. So the pharmacists who voiced stigmatizing attitudes about people who use drugs and mistrusted the physician prescribers, they engaged in a whole host of different strategies to greatly curtail MAT dispensing. As I said, two simply refused to dispense MAT altogether. Others refused to take any new customers. And I want to be clear that about half of the sample of pharmacists did not express stigmatizing views about people who are using drugs to get high. They did not voice skepticism about the prescribing physicians, but they, though, still had to navigate the DEA cap, often by rationing buprenorphine to local customers or to long-standing customers. The DEA cap, then, is not the only barrier to prescribing buprenorphine, but it's a clear barrier for those pharmacists who want to be prescribing buprenorphine to meet local need. As one pharmacist said in one of our interviews, you can have all the funding in the world to have these programs like Care to Hope down the road to prescribe all of these MAT medicines, but if your pharmacies can't physically get it from the wholesalers, it isn't going to do anyone any good. So I want to just check in about time. Should I be wrapping up by like 10:30?
No. You've got another, I'd say 15
plus
okay. Minutes.
Okay, I'm just going to keep talking then. So let's dive into how features of the risk environment might intersect to affect syringe access. The Scott County outbreak precipitated several legal changes in the Kentucky political environment. Most notably, in 2015, Kentucky made it legal to operate a syringe service program, or SSP. And since the passage of that law, there's been an expansion of these syringe exchange programs across the state at a scale and a speed that I have never seen before. So these stars are the new programs that have opened up. So between 2015 and now, Kentucky opened up scores of syringe exchange programs, most in very rural areas, including 7 of the Care to Hope counties. The presence of these programs has been vital for people who use drugs in the area. As you may recall, the survey results showed that high numbers of people either obtain syringes directly from these programs or get them from these programs through friends. And we've heard repeatedly from qualitative participants about the importance of the local program for accessing sterile syringes and other injection equipment. And this quote, I think, exemplifies this. We also have a lot of quotes just from participants who talk about the fact that this is the only healthcare service provider who treats them with dignity. That's something that we see certainly in cities as well. But there is a hitch, as there always is with syringe exchange in this country. The 2015 state law in Kentucky requires that every program has to be approved by 3 local entities before it can open. So the local fiscal court must approve the program, the local city council must approve the program, and the local board of health must approve the program. And now the fact that scores of these programs have managed to get through this process in so many counties in so little time is a tribute to multiple champions at the state and local levels. So there's a harm reduction coordinator at the Kentucky Department of Public Health who's worked tirelessly to support the local approval process. In the Care to Hope project area, the 2 health district directors have been highly strategic and creative in their efforts to win local approval for these programs. They're reaching out to key decision makers and educating them about the program and its positive impact on communities. They're enlisting local advocates to attend the meetings where the votes occur and kind of testify, kind of share personal stories. And they've been very, very successful in this work. But despite these successes, these different municipal entities and also funders add stipulations at different levels about what these programs can and can't do. So these are often elected officials who are facing re-election, maybe in counties where people are ambivalent or potentially in opposition to these programs. So most notably in all the Care to Hope counties, syringe service programs have to engage in what's called 1-for-1 exchange. So that is, if I come to the program with 10 syringes, I'll get 10 back and no more. If I come with 200 syringes, I'll get 200 sterile syringes back and no more. People can get 40 syringes on their first visit, but then they can only thereafter get as many syringes as they bring in. The number of syringes that someone might need, though, it really does change over time. So people may shift to a drug that they need to inject more frequently, or maybe their dependence intensifies, so they have to inject more frequently. Or maybe they stop injecting for a time, they throw out their syringes, and then they resume, and they want to have sterile syringes when they restart. In the conversation depicted on this slide, the participant has had his syringes stolen because they're still a precious commodity, and that's fairly common, I think, in this area. But because of the 1-for-1 rule, he couldn't get any new syringes from the program. He'd already gotten his initial kind of starter kit of 40 syringes. So instead, he had to buy syringes off the street. His friends very kindly brought him some of their syringes that they'd gotten from the program. But that, of course, creates a problem for them, right? Because they now don't have the number of syringes that they might need. So while these new programs, I think, are making important inroads, the 1-for-1 policy curtails their full potential as a public health intervention. And there remains a scarcity of syringes, sterile syringes, in this area. I want to turn now to another dimension of the local risk environment. So within this setting of politically driven syringe scarcity, many participants expressed a high level of fatalism, and fatalism really permeated the social environment. The quote you see here, I think, illustrates this fatalism quite eloquently. As you can see from the end of the quote, the participant tried to use sterile syringes when she first started to inject, but within a week to 7 days, she had stopped trying. And she stopped trying because it took too long to get sterile syringes, and also because the people in her social network so clearly felt that drug-related infections, most notably hepatitis C, they were just inevitable. And so in this social context, the participant concludes that there is just no point in going the extra mile to get a sterile syringe. Social norms also matter. So sharing injection equipment is a potent norm within many participants' micro-level social environments. In this quote, for example, the participant is talking about times when people are sharing drugs, and as a natural extension of that, they're also sharing syringes. And this sharing norm arises time and again in the interviews and can be so powerful that some participants who want to inject with a sterile syringe simply opt to use drugs alone so they can avoid feeling this pressure. It's hard for them to navigate that in a social situation. One thing I've been really struck by is another feature of participants' social environments, and that's this recurring pattern of intergenerational substance misuse. So time and again in these interviews, participants talk about, sorry, I wanted to make sure that I was on the right slide. Participants talk about parental substance misuse, about aunts and uncles who misuse opioids, about cousins and siblings who inject methamphetamines, and so on. And often the participants describe using drugs with these individuals. So they're injecting drugs with their parents, aunts, uncles, cousins, and siblings. So familial substance misuse isn't something that they're just observing from a distance, or that they know about in the abstract. Their parents and children, aunts and nephews are actually sitting down together and using together. And that's new for me. I think I've been used to urban environments where actually parents do their best to protect their kids from their own substance misuse. People may know about it, but they don't try to use in front of someone, and they certainly are not using drugs together. So this is quite a different environment. So to put all these different pieces together, there are powerful, I think, macro level and micro level social and political factors that drive people to share injection equipment in this area. Policies create a scarcity of syringes. Within this context of scarcity, there are strong social norms supporting syringe sharing. And you can imagine that these norms might be particularly strong if you were using drugs with a close family member, where sharing is an expected and natural component of the relationship, right? You expect that family members will share resources with you. The adverse impact of these policies, social norms, and intergenerational substance misuse on HIV risk may be compounded by, I think, a strong sense of fatalism, that regardless of what you do, you will become infected with a bloodborne virus. At a decision point, I guess I'll go through this next illustration and then wrap up. This kind of third and final illustration really focuses on how features of the political environment intersect with the economic and physical environments. And just as a warning, I think each feature may feel kind of distinct and fragmented from the others as I speak, but I promise you that at the end they all kind of weave together into a story. So let's start with another feature of the macro level political environment. So this time it's the police. I came into this work assuming that the police would not really be a major force in this area. I've understood the war on drugs in this country to be very motivated by white supremacy. So I naively felt that in an area where almost everyone was white, you wouldn't really see the war on drugs. It would be quite dormant, and I was very, very wrong. According to participants, police are very active in the lives of people who use drugs in this area. Participants report that police aggressively enforce drug possession laws. They also report that a conviction for drug possession can have dire consequences, including being incarcerated for a year or more, as this participant describes in the quote on this slide. And I've been learning that in the US, most growth in jail-based incarceration rates is actually occurring in rural and suburban areas. Kentucky has actually been at the forefront of this growth. The number of men incarcerated in Kentucky prisons increased by 5% in the last year, and the number of women incarcerated increased by a startling 13 or 14%. These increases are largely driven by drug-related offenses, and this intensification of drug-related law enforcement activities seen in U.S. rural counties was clearly felt by our participants, and was a key feature of their political environment. So I've had to really revise my understanding of the war on drugs. I think it certainly started as a way to maintain white supremacy, but it subsequently gained a life of its own, and so it's unleashed also in predominantly white areas as well. So let's turn to the economic environment. So at the macro level, participants reported that there were way too few local opportunities for work that paid adequately. And this is illustrated by the quote from this man who describes his fruitless and repeated efforts to get a job in all of the local fast food restaurants. As a consequence of these limited earning opportunities, many participants experienced housing insecurity. So if you recall from the survey, about a third of participants in the Gateway to Health cohort reported being homeless in the past 6 months. In the qualitative sample, participants reported couch surfing, living outside under bridges and in the woods, and sharing inadequate housing with other people to make rent. And that's illustrated in the second quote on this slide. And I want to just continue talking for a moment about those bridges and woods where people are kind of camping out, and turn to the physical environment for a moment. First I want to just highlight the clear joy that many participants took in their rural surroundings. They went camping and hiking in the Appalachians. They had barbecues by the lake. That was an important part of their life. Many of them really liked the remoteness of their homes, that they could come out of their home and not see anyone for miles around. And as you can see, it's a really, truly beautiful area. One consequence, though, of living in a rural area is that people have to travel long distances to reach basic amenities. And for this population, those amenities include drugs and also injection equipment. So let me pull all of these kind of seemingly disparate ideas together, or try to do that. So in this rural county, participants often had to travel, sometimes quite far, to acquire drugs. And when they make these journeys, they travel on roads that are often patrolled by officers who are prioritizing drug-related law enforcement. The consequences of getting arrested for drug possession are really dire, but you might actually be incarcerated for a year or more. And as a result, once participants have bought drugs, there's a really strong incentive to use them as fast as you possibly can before the police can catch you. Now, while most participants expressed a strong desire to be using at home, where they would have more control over their setting and over the people who were present, they might have easy access to sterile injection equipment, many reported that it was too dangerous to try to travel the distance between where they bought drugs and also where they got home, where they lived, on these very heavily patrolled streets and roads. Other people couldn't inject at home because they were homeless, or they lived with other people and didn't have the privacy that they needed to inject at home. So as a consequence, many participants discussed injecting in what they call trap houses, and that kind of maps onto shooting galleries for most of us who've been doing this work in the cities. Trap houses are features of the physical environment that are sites of very, very high risk. These are homes where people often gather to buy, trade, and use drugs. They're typically operated by the owner or the renter of the home, who sells drugs to customers and then allows some of the customers to use drugs on the premises. Trap houses, they solve the problem of how to get from where you buy drugs to where you use drugs in a rural area without encountering the police. But they're also sites of tremendous HIV risk. So there's a high volume of people cycling through trap houses, as is illustrated by the first quote. People flow in and out of these places constantly. Because of this high volume, trap houses have many, many discarded used syringes strewn around. And these are syringes that people often pick up and inject with, as is illustrated by the second quote. So despite the fact that participants greatly prefer to inject at home, features of the political, economic, and physical environments where they live push them towards these high-risk settings. So let me just turn to some kind of implications, and then we can move into the discussion. If other studies support these preliminary findings, then I think they highlight several interventions into the risk environment that might be able to reduce vulnerability to future HIV outbreaks in this rural area. So let's start with the macro level policies, the political environment. So first, as we've been talking about, the DEA needs to remove buprenorphine and other MAT medications from the opioids that they survey, right? They have to remove them from that numerator and the denominator. I think that's an easy shift. Not under this administration, but soon. Second, the Kentucky law permitting syringe service programs needs to be amended to remove that requirement that so many different political entities must approve these programs. These layers undermine these programs' true public health impact. And third, in many states and cities, we're finally beginning actually to roll back the war on drugs. That's evidence in municipal and state efforts to allow recreational and medical marijuana, and in efforts to release people from prison who received lengthy sentences for non-violent drug offenses. Rural areas could also embrace a similar path and work with law enforcement maybe to connect people to harm reduction programs. Turning to interventions at the more micro-social environment level, social networks are clearly very powerful in this area, and I think they could be leveraged to promote health. So interventions could try to alter social norms so that they sought to promote, to protect the community by discouraging the sharing of used injection equipment. These powerful networks could also be leveraged to distribute sterile syringes, right, through things like satellite exchange or secondary exchange. And finally, these networks could also be harnessed to advocate collectively for changes to the political environment that constrain syringe access and other harm reduction opportunities. There are many, many other opportunities for intervention, and my key take-home point is that we are still in this window right now where we can act to actually prevent HIV. in this rural area and in other rural areas. There have been no HIV outbreaks in Wolfe County or in any of the other Care to Hope counties, but I think this window is starting to close. There's an HIV cluster to the north of the Gateway Health District that the CDC was recently deployed to investigate, and all of the ingredients needed for a major HIV outbreak in the Gateway District and also the Kentucky River District are in place. So we need to act now, right? We have decades of experience to draw on from urban areas, from other countries. We need to apply it to this new setting. So before I wrap up and open up for questions, I want to just acknowledge the study participants, our team, and also our funders. And now I'll take some questions.
That was great, very rich and clearly a challenge.